Hi, everyone. Welcome back from your meal. So nice to see everyone. I hope you had a nice break and are enjoying the session so far. I am Dr. Jill Yersak, the Medical Science Liaison for Biogen in ALS. I'm happy to introduce you to our next session speaker, Dr. Regina James, who will be presenting on mental health and patient science, how COVID-19 reframed our research, outreach, and clinical community linkages. Dr. James serves as the American Psychiatric Association's Deputy Medical Director and Chief of the Division of Diversity and Health Equity, where she's responsible for ensuring that diversity and mental health equity objectives are valued and operationalized as vital components of the APA's mission. She's a child and adolescent psychiatrist with over 25 years of experience, providing leadership and direction in the planning, policy development, and implementation of national and international health disparity programs and initiatives for children and families. Dr. James serves in numerous leadership positions, including Chief Medical Officer and Senior Vice President at 2M Clinical, a clinical research organization and consultancy. Also as Director of Clinical and Health Services Research at the National Institute on Minority Health and Health Disparities, where she led promotion and development of scientific programs that address gaps in minority health and healthcare disparities, and also served as the director of the Office of Health Equity at the Eunice Kennedy Shriver National Institute on Child Health and Human Development, where she led domestic and international programs addressing maternal and child health disparities. It is my pleasure to introduce you today, Dr. James. It was very nice meeting you in person, and please take it away. Thank you.
Thank you. Thank you so much. I guess we can go to the next slide, which I believe has sort of my background. Great. So let me just first say, it's interesting. This conversation is around patient engagement. I'm coming on after lunch, so I'm really hyped about how am I going to maintain audience engagement. I know you all are probably like, kind of going downhill in terms of attention span, but I hope that I can keep your attention on this important topic. So let's get going. This first slide I have actually is just to really orient you to the lens that I'd like to use as I talk about patient engagement. So it's the American Psychiatric Association, so a 501c3 membership organization. So the lens that I'll take in my discussion is really going to be from that perspective as a membership organization for psychiatrists and trainee psychiatrists that we hope will go into the world and be culturally competent and really engage their patients in a productive way. So next slide, please. So this is sort of the flow of the next, 30 minutes or so. So first, I always like to provide definitions because I want to make sure that we're on the same page in terms of when I speak about patient engagement and your understanding as well. So defining patient engagement in mental health, and then talk about the scenario of mental health and patient engagement before COVID, and then sort of the impact of COVID-19, the pandemic, on mental health and patient engagement. And then I'd like to provide you with some select examples from the American Psychiatric Association of what we did to respond to COVID-19, the impact and patient engagement in mental health. And then really wrap things up by sort of summarizing priorities and how we need to prioritize re-engagement. So next slide, please. So patient engagement, next slide. So in terms of the definition, it is, some people call it patient engagement, others will say person and family engagement, and others will say patient-centered care. But I think the bottom line, and you all know this, is really ensuring that there is a respect and being responsive to patients' preferences, needs, and values. Whether it's the patient directly or is the patient and their family, making sure that they are partners in the healthcare environment. Next slide, please. So in the mental health care arena, optimal patient engagement will give you 4 of the following, right off the bat. Obviously, we're looking for positive mental health outcomes. Also, higher quality patient-provider communication, better healthcare quality, and of course, decreased costs. Next slide, please. So I'm going to, again, take this from the lens of the American Psychiatric Association and really talk about enhancing patient engagement through two sort of avenues, education and awareness. So with our members, we work with our members to ensure that they're culturally respectful and responsive to the needs of their patients. And because of my role at the APA, really working around making sure that marginalized and minoritized communities' needs are being met, that's sort of the lens that I'm bringing to the discussion. So that's what we do with the members directly. And in terms of the patients that are served by the members, we work in collaboration with our members to provide information, again, education and awareness about mental health services. Thus, we want to empower them to be more informed and actively engaged in their healthcare. Next slide, please. So let's set the scenario, pre-COVID, mental health and patient engagement. Next slide. So let's just say that the scenario or the scene was not optimal when it comes to mental health needs before COVID hit. So the next few slides are really going to just give you sort of a broad brush, picture of what was happening before COVID, why we weren't at the place that we really needed to be in terms of meeting mental health needs of individuals. So before COVID, many folks were dealing with unmet mental health needs, particularly, again, marginalized and minoritized communities. So despite efforts that have been made across, improving access, the fact that there are less providers that are able to serve patients in terms of face-to-face services, all of these things that were kind of going on to try to address it, there were still a significant number of unmet mental health needs. So when you talk about patient engagement, you have to get them into the door. They have to have access before you can even engage them. So if you're starting off from a place where there are a significant number of unmet mental health needs, that sort of puts you behind the 8 ball. Next slide, please. So this next slide just sort of gives you some data behind, what I'm talking about. So if you look on the x-axis, it's the sex, the y-axis is percentage, and the slide really demonstrates by age group the percentage of unmet mental health needs. So again, orienting you, the light blue bar is 18 to 44. So we're talking young people who just graduated from high school and who entered the workforce. So that's the light blue bar. The next blue bar is actually those who have been in the workforce, relatively seasoned and probably approaching, retirement. And then the darkest blue bar are those over 65. So the first thing that stands out, at least to me, is that when you look at women versus men, no matter if it's 18 to 44, 45 to 64, or over 65, women in general have unmet mental health care needs relative to men. The second thing you'll notice is that the light blue bar, which represents those who are kind of getting out of, entering into college and into the workforce, you'll notice that no matter if it's a man or a woman, the unmet mental health need is highest during that time period. So when they're entering the workforce is when that unmet mental health need is highest. Next slide, please. So just wanted to make those 2 points. I bring up this slide about the Affordable Care Act because, the good news was that the Affordable Care Act did have an impact on uninsured individuals. You need the insurance to get access to get your mental health care services. So before the Affordable Care Act, there were more than 48 million people who were uninsured. So after the ACA was passed, the uninsured number dropped to about 30 million by 2018. So that was a good thing. But unfortunately, despite the ACA, many people are still, uninsured. And even those who have health insurance often don't have mental health services coverage, either due to expensive co-pays or deductibles, et cetera. So that's sort of another piece of the puzzle pre-COVID. Next slide, please. The other issue around mental health care services is not only the access, but the long waits that people have to experience before they actually see a mental health care provider like a psychiatrist. So nearly half of Americans have had to or know someone who's had to drive more than an hour round trip to seek treatment. So that kind of is a barrier in itself. So distance-wise, as well as how long it takes you to actually get on the schedule to actually see a mental health care provider. 96 million Americans, or about 38%, have had to wait longer than 1 week for a mental health treatment. And this is like good numbers. On average, it can actually be a lot longer, as many of you, I'm sure, are well aware. Next slide, please. So then there's the other piece of the puzzle, which is difficulty navigating the process of identifying a psychiatrist or other mental health care provider. It could truly be overwhelming to really try to identify, where do I even begin to look for a psychiatrist or other mental health care provider? Like, do I start with my internist? If it's a kid, my pediatrician, my family physician? Do I check with my insurance company to make sure that it's actually covered? Do I go online and look at some of those resources? Do I ask family, friends, or maybe someone at your church or other religious engagement? Like, what do I start and what do I ask? So it can actually be very confusing, even when you choose and get to that point where you actually want to seek mental health services. And the picture on the left, just of note, is the Arc de Triomphe. I hope I'm saying it right in French. And you know how hard it is to actually get to that centerpiece, although it looks like it's a simple go around the corner, but when you're actually physically there, it's just too many tributaries and it's very confusing. And it just, in my mind, reminds me of the difficulty that all of us experience navigating healthcare in general, but mental health care specifically. Next slide, please. And then, of course, there's the issue of shortage of behavioral health providers. That's huge. People living in mental health care shortage areas are really, really suffering in this capacity. And there's just a shortage of psychiatrists in particular that can actually provide mental health services. But there's a shortage of other mental health care professionals as well, particularly when you're talking about rural areas or urban areas, et cetera, and particularly for those who need to have very severe mental illness treated. So in addition to the fact that there's, a difficulty in terms of access, there's insurance issues, et cetera, there's also a shortage of behavioral health providers. Next slide, please. And then goes without saying, just the history of, from different cultures and different perspectives about mental health. And, some cultures feel, you just get it together, just, pray it away, just be stronger, just, put the right pant leg on, the left pant leg on, and go out the door and do your thing, more, as opposed to looking at mental health being a part of your overall physical health. They go hand in hand, you can't disconnect them. But there is this sort of negative picture or stigma around mental health that also impedes someone who could benefit from mental health treatment and services. So next slide, please. So that's sort of the scenario, which is not necessarily a pretty picture of sort of mental health and services pre-COVID and thinking about all the unmet mental health needs before COVID even hit. So now the question, as was prescribed in this particular session, was looking at patient engagement in the mental health arena. So now if you're starting off sort of behind the 8 ball before COVID, then COVID comes and it hits, or at least it becomes a public health emergency being declared in February 2020. By April of 2020, it really takes a significant impact on everyone, right? Symptoms consistent with depression and anxiety really skyrocketed. So if you had unmet mental health needs before, you really see sort of the unmet mental health needs now. It's as if the Band-Aid was ripped away, and so everyone is suffering. So those who are marginalized and minoritized have been significantly and disproportionately impacted by COVID. So therefore, less access, less treatment, and less engagement with patients. Next slide. So now let's talk about post-COVID-19 and patient engagement and how and what we could potentially do. So again, as I mentioned, the pandemic essentially exacerbated mental health symptoms and unmet mental health needs, right? So it disrupted mental health services across countries. More than 40% of the countries had lost full or partial, services. They had closure. And during August to February, the percentage of adults with symptoms, as I mentioned before, just skyrocketed. And 3/4 of mental health services in schools, particularly for kids, and workplaces were disrupted, right? Because we weren't able to go to work and we had to, be secluded. Next slide. And again, I just like to really share this at any opportunity that I can with COVID and the mental health. There was a disproportionate impact on certain individuals, such as racial and ethnic minority communities, LGBTQ+ communities, individuals experiencing homelessness, individuals who were incarcerated, those with severe mental illness, drug addiction, and immigrant populations. So again, with COVID-19, this really had an impact on a number of communities. And with kids, I just wanted to make sure, they weren't in school, right? So they were at home. And so disparities, started to show up in terms of access to quality health services as well. Next slide. Particularly the color. Again, this is just underscoring that there were, with COVID, disruptions in routines and relationships, et cetera, and that the emergency department visits actually went up more than 50% among adolescent girls. So remember that slide we shared earlier, looking at women versus men in terms of unmet mental health needs. Women were, at whatever stage, had more unmet mental health needs. So no surprise, emergency department visits, attempted suicide rose about 50% among young girls. Next slide, please. So as an organization, as a membership organization, with all of this happening, it's really dealing with sort of a not so optimal scenario before COVID and a less optimal scenario post-COVID, and really trying to utilize a platform of a membership organization that interacts and engages with psychiatrists and trainee psychiatrists. How can we really start to bridge the gap, fill in the gap, really develop a bridge to really enhance awareness, education, access, and hopefully have that impact on engaging patients in mental health. So in terms of education and awareness, one of the things that we did was specifically look at, from experts in the field in mental health, what was the impact of COVID-19 on the various communities of color. So we had a series of fireside chats where we not only targeted psychiatrists, but we also targeted the communities that they served. So we targeted just the general community to really learn about and become educated about sort of the impact, what resources were available, what they could do, some recommendations, et cetera. So we thought that this was a really great idea and it was really well received. And we started with the Black community where we had Dr. Turner and Dr. Kismikia Corbett. I'm sure you remember her with the development of the vaccination at NIH, really talking to not only psychiatrists, but the communities about some of the myths about what was going on with vaccinations, what was necessary, what it was important for them to really, take care of their mental health needs during this time period, what resources were available, et cetera, really sort of underscoring that need to address patient engagement. We also looked at other communities as well. So the Asian community, we looked at the Latino community and the Indigenous community. Again, bringing in experts in the field to really talk about how can we move the needle in terms of awareness, engagement, and getting them into the services that they need. Next slide, please. Policy is obviously very important. So we worked with our Division of Government Relations, and it was post-COVID, but still we were doing everything virtual. So we did have a congressional briefing, really talking about the policy solutions to mental health care disparities. And that was our actual panel members. Dr. Vivian Penn was actually the president of the APA at the time. We had Dr. Lisa Cooper from Hopkins, Dr. Ng, and Dr. Gordon really talk about this on a federal congressional level to really talk about solutions and next steps. Next slide. The interesting thing about, I think, post-COVID-19 was this, I call a resurgence in understanding or appreciating the significance of the role of social determinants of health on one's overall health and mental health specifically. Again, so we also leveraged that opportunity to really talk about the importance and the significance of really addressing an individual's needs outside of their physical and mental needs, like, food insecurity, transportation, et cetera, because again, 90% of health outcomes are influenced by social and behavioral factors. So we wanted to make sure that we, again, brought up the significance of, importance of, and really emphasize this with our psychiatrists and the patients that they serve about why these aspects need to be addressed. Next slide. So in that vein, we did another series of educational and awareness seminars. We really started back at looking at sort of the first case study of social determinants of health with W.E.B. Du Bois, and really laying it over how can we take all of this history and make differences in mental health and mental health services. And so we, again, looked at just different angles. I say different angles of the same elephant, looked at, the role of genetics and genomics. And really an interesting one was looking at the role of place, not necessarily race, on mental health and the disparities, particularly after COVID-19. And then also, how can psychiatrists in their day-to-day work integrate this concept of social determinants of health as they deliver care in a mental health setting? Next slide, please. And then we also wanted to, again, in the spirit of education and awareness, to really develop new curriculum that talked about addressing disparities, because before you can even get to patient engagement, right, we want our psychiatrists to be culturally competent. We want for them to understand some of the issues that are going on that impacts why a patient may not come to the psychiatrist. We want them to understand the role of other factors that may influence whether they come and whether they stay in treatment. So we had a series of new curriculum that we developed around social determinants of mental health, racism, cultural competence, et cetera. So that was another way that we approached it. Next slide, please. And then, of course, telepsychiatry. So now we're getting down the route to that not only does mental health face, but all of health faces in terms of telemedicine post-COVID-19 and the impact on patient engagement. So telepsychiatry really took a boost, I guess, so to speak, post-COVID-19. And there was just there was a robust evidence base that really showed that telepsychiatry led to improved outcomes and higher patient satisfaction. So as it relates to patient engagement, telepsychiatry really did have an impact. But there's a caveat to that. Next slide. Let me also mention, this is APA's policy on telepsychiatry. Again, telemedicine and psychiatry using video conferencing was really effective in increasing access to care. So I think this is something that we should, and not only psychiatry, but all areas of medicine, really, I know, leveraged telemedicine during post-COVID to enhance patient engagement. And this is APA's policy on that. Next slide. But my next point I was going to say was telepsychiatry is helpful, but we just want to make sure that we understand that there are certain communities that may not have the technology to engage in it, but know that it did actually make a significant difference for many folks needing mental health access and mental health services. Again, the APA has a telepsychiatry toolkit for those who might be interested, and best practices in video conferencing. So just wanted to add that piece in there. Next slide, please. Again, so as I mentioned or alluded to, there are some considerations, utilizing telepsychiatry. It can enhance patient engagement, but there are some considerations that I think that need to be sort of thought through. And that is, at least from the provider side, it costs. So there's some investment in telehealth platforms, but you can still use things like FaceTime and Zoom. Resource-limited organizations may not have sufficient bandwidth really to achieve reliable internet connection to actually implement telehealth. And then there's a piece of, workflow training for the staff on telemedicine technologies that may require some additional time and resources. So just some considerations to think about. It is an excellent tool, but there are some provider-facing considerations, and there are also patient-facing considerations as well. Again, I've mentioned before, access to telehealth may be challenging for some communities. So low-income patients in rural areas, they may not have that access to telehealth. And so, again, just keeping those issues in mind. Next slide, please. So looking ahead, really legislation, I'm a strong advocate of policy. There is an Advancing Telehealth Beyond COVID-19 Act to really continue the improved patient engagement in the mental health arena. Just of note, it was passed in July 2022 in the House. It provides flexibilities that can continue to apply up until December of 2024. And so it also, I think it's very important, delays implementation of certain in-person evaluation requirements. So you don't have to have those for mental health telehealth services until January of 2025. So again, just, coalition building around supporting Advancing Telehealth Beyond COVID-19 Act of 2022 is something to consider. Next slide. So I will end on this in terms of patient engagement. So I sort of provided you with sort of a whole bunch of puzzle pieces of where we weren't in the most optimal scenario of access, getting services, and patient engagement. And then COVID-19 sort of really exposed some of those deficiencies. But things such as telepsychiatry that was mentioned can actually help those communities who have the technology to gain more access, and you can actually engage patients in that capacity. Again, leveraging just technologies in general as we prioritize re-engaging patients for mental health services. So whether it's telehealth, whether it's text messages, phone calls, just essentially leveraging technology to facilitate effective patient engagement will be crucial. Educating providers to administer culturally and linguistically sensitive care, because once you get them through the door, you want to make sure that you connect, and so that you're providing culturally and linguistically sensitive care. Hence, some of the courses that we developed this year for our members to really underscore the need for culturally and linguistically sensitive care. Educating communities about mental health and empowering them to actively engage in their care. And so some of the other things that we did in the APA was we had our first health fair that we hosted at Howard University Hospital, where we brought together a number of mental health service providers in the DC, Maryland, Virginia arena into one space so that the community could really see and learn about mental health. What is it? What are some of the services necessary? Really bringing everything to the community to make sure that they are aware of resources in their area. So educating the communities about their mental health and empowering them to make great decisions. Encouraging patients to weigh in on their medical options, right? Again, but you need that connection with the patient, And once you establish that connection and that relationship, encouraging them to weigh in by asking questions. Advocate for legislation. I just mentioned one earlier. There's a number of them, but I think that's one around at least telehealth. Legislation that increases not only telepsychiatry, but the number of healthcare providers that reflect the populations that they're served. And there are a couple of those I know. And then advocate for legislation that improves access to mental health care for all. Next slide. So I'd like to thank you and open up for any questions that you may have. Again, thanks to the National Health Council for providing me this opportunity and platform to really share what our organization is doing around patient engagement. Thanks again.
Thank you, Dr. James. Mental health is so important and has really come to the forefront since COVID. So I really appreciate you taking the time today to really give us a great overview of what you're doing and how organizations across the country can do to improve mental health. So this is really wonderful. So I have a couple questions. Please feel free to add more questions to the Q&A box, and then we have about 15 minutes. So let's get started. So the first question I received is, I've heard some begin to state a preference for the terminology social drivers of health over social determinants of health. Can you speak to this evolving terminology and what impacts it may have to the discussions around significance of these impacts on the communities of color?
So I actually do not have a preference between social drivers and social determinants. Drivers would probably be more, these are things that influence health outcomes and don't necessarily determine the actual health outcome versus the terminology social determinants. Some choose to use social factors. The issue is, regardless of the nomenclature that we use, the issue is, and I think is the most important part, is understanding that there are social entities that our society, where we live, learn, work, and play, essentially, does have a huge impact on our health. So if we're looking with sort of a very circumscribed lens at our interaction with patients, and just looking at the symptoms and not necessarily looking at the environment in which they live and things of that nature, I think you're going to miss a lot. So I am open to, social determinants, social drivers, social factors, social entities, but I think the real key piece is to make sure that we take those into consideration as we are engaging with our patients.
That makes a lot of sense. Thank you so much. So the next question is, could you tell us more about the Leadership, Equity, and Diversity, the LEAD initiative that you spoke about earlier?
Oh, absolutely. So just of note, I came to the American Psychiatric Association about 2 years ago. And in the process, one of the things that I wanted to do and really work with our members doing is having courses not only for the members, but the member trainees, because they're our future. So to really expose them to courses around, anti-racism, to expose them to courses around how to deal with microaggressions, et cetera. So that is really the sort of birth of the Leading Equity and Diversity Institute, or the LEAD Institute. So it was really targeted to our younger trainees to really get them, some sea legs and vocabulary and understanding around the impacts of these entities on one's health. So the LEAD Institute is really two-part. It is these courses or curriculum that is offered to our members and our member trainees that really focus around sort of the diversity, equity, inclusion arena. And it is also what I call, it's not necessarily a mentorship, we call it an advocate program. So it's an advocate protege program. So we have engaged our leaders within the American Psychiatric Association to volunteer their time to partner up, in a sense, with our young psychiatry trainees, particularly those who are of color, to really help them in terms of not only providing guidance and mentorship, but also really being an advocate and hoping that this relationship turns into something where that person who is in a leadership position can use their sort of leadership clout to help an up and coming psychiatrist really learn and begin to lead in this area around mental health and mental health care. So the LEAD Institute is really two parts. It's curriculum and it's an advocate protege program.
Well, that's wonderful. You know, keeping your students engaged and wanting them to stay in psychiatry and then go on to mentor themselves.
Yes.
It's a really beautiful thing. So this is such a great initiative. I'm so glad someone asked you to explain more about it. So thank you.
Absolutely.
The last question I have, and then I have a couple of my own questions, is another group of people negatively affected by COVID is the disabled. What considerations for this group did the APA make around that? Or did you know of it? Or do you know if this group is considered in future plans?
Can you repeat the first part?
I'm sorry. My screen was moving. So
okay.
Another group of people negatively impacted by COVID is the disabled. So what are your considerations at the APA around the disabled, and or if you don't have any now, are you considering future plans around the disabled and mental health?
Actually, it's an interesting question, and we recently had, like in the last 2 weeks, of the definition of marginalized and minoritized. So that's why we use both of those terms, because minoritized typically refers to the racial, ethnic piece or gender identity, et cetera. And then marginalized can be any group, essentially, which includes those with a disability. Coming from my history coming from the National Institutes of Health, that is actually a part of the definition of those who are diverse, like diverse communities, racial, ethnic, those from low socioeconomic status, and those who have a disability. So yes, we are moving in that direction.
That's wonderful to hear. So I have one of our panelists is going to come in and ask a question live. Go ahead. Hopefully this works.
Okay.
Let's see. Soka? You're on mute. I don't know if this is, if not, we can just type it in and I'll ask the question. Okay, so, Zoom's always fun. You never know what's going to happen.
Roll with it. We'll just roll with it.
Okay, so I have a question. So throughout your talk, you talked about unmet mental health care needs, and a lot of the impact that you mentioned were with women over men. Really high mental health issues. And then also it struck me, you talked about young girls who had a higher suicide rate during COVID, which really struck me. So can you comment more about why you think this is happening, and then how us as organizations across the country could help with mental health, especially thinking about women, especially those years you talked about, age 18 to 44.
Right. So I think, anecdotally speaking, and actually studies have supported, I think that it could be because women are more open in terms of coming to mental health providers for their services, therefore they can be documented or noted that they have it. Another is, I think that in terms of some of the issues growing up as young women, actually have more exposure to sort of fitting in or trauma and things of that nature, just a higher risk for that as well. And then you have the hormonal issues going on as well. But it's interesting that that is the case for young girls who are experiencing in higher numbers. And even more interesting is now we're seeing a higher number of young Black girls in particular who are experiencing increased mental illness and increased rates of attempted suicide.
Well, thank you. Thanks for shedding more light on that. It just really struck me. And I want to ask you what your thoughts.
Absolutely.
So thank you.
And did you ask about what could we do or something as a group?
Yeah, as patient advocacy organizations all over the country, what do you think we could do together to help mental health in women and especially women of color?
Right. So some of the, I'm always sort of on that policy side, first of all. So there are a number of policies and legislation that are out there that I think as various organizations are represented to the National Health Council can come together to actually support some of the legislation that can make a difference in meeting, in improving access to care and improving, how do we deal with suicide rates in young people? How do we deal with suicide rates in younger women, et cetera? So there's a lot of policies that are out there that I think will have more of an impact if there were more people sort of coming together to really, speak at the local, state, and federal level about how significant it is, whether it's with statistics and data or whether it's through storytelling, having that opportunity to speak individually, but I think more impactful as a group. So just sort of a coalition of individuals. I know that you have a large coalition of mental health organizations already that are a part of the National Health Council, but really sort of driving that legislative piece together. I think also just from an access to care sort of scenario, I think again, really pushing for the collaborative care model. Most people, the collaborative care model is essentially when you have, so the lead person is your primary care physician, whether it's your internist, your family medicine doctor, and then you have a psychiatrist who's on the team who serves as a consultant, and then you have a case manager, right? So most people will probably feel comfortable going to their internist or their family doctor to tell them everything. So if that can be the access through the collaborative care model, the psychiatrist and the case manager can really, provide that mental health input, treatment recommendations, follow through with patients. And I think that is one area that has strong evidence base, actually, but has not been adopted widely, but has truly shown that it can impact access in terms of improving access. It can also decrease cost. And so just thinking about someone at a community mental health center, someone who's going to the pediatrician, someone who's going to their internist, having and pushing stronger again for legislation that supports a collaborative care model, I think it can be huge, can have a huge impact. It has already had significant positive impacts, whether it's sort of the Medicare, Medicaid environment as well. It has already shown to prove itself. And if we can just get wider adoption of this sort of healthcare model, I think that can have a huge impact as well.
Yeah, I agree. I think that going to your regular doctor and having those resources there or near there that someone you trust is going to be huge, and that would decrease cost and confusion and help people be more comfortable talking about their mental health. I think that's a really wonderful thing. And also about coming together in coalition. I've seen this work I'm in the ALS space, and that coalition, that power numbers can really make a big difference. So yeah, I agree. Encouraging people to come together with all these great organizations across the country can really make a big difference.
Right, okay. Right. And patient engagement. It has a significant impact on patient engagement. So I would definitely say. I think it's HR 5218, just in case if you want to know.
HR 258. I'm writing it down. I'll write that down too. I think so. We're very close to the end, so I think I'm going to take moderator rights and end the sessions a minute early, so because I don't want to rush you through another question. But thank you so much, Dr. James, for your time today. I learned a lot. I'm sure everyone on the line today, we have almost 100 people on the line who can really benefit from this. And so thank you so much for joining us. And thank you to the National Health Council and for having me today to moderate. So we're going to break for 15 minutes, which includes a 1-minute breathing exercise. And we look forward to seeing you at 1:45 p.m. Thank you so much, everybody. Thank you, Dr. James.
Thank you. Thanks again.
Take care.